go live. Okay, good evening, everyone. Assalamu alaikum. I'm Dr. Noor, the moderator, and we have currently with us our first speaker, Dr. Farah Ikramuddin. She seems to have a very, very long CV and credentials to her name. She is an alumni from Deccan Medical College from 88 batch, or one of the earlier batches from Deccan. She has done her residency from University of Pittsburgh. And following that, she has also done residency in rehab and physical medicine. So currently, she's working as assistant professor of physical medicine in University of Minnesota. But apart from that, she also been a director of internal medical residency program from 2010 to 2017. She has done a Master of Health Administration. She's currently a director of her institute, and she's also involved in education, medical school admissions, and also she wears an administrative hat as well in her current role. It's been a pleasure and honor to have Dr. Farah from America. She has agreed to talk on the very important issue of rehabilitation, which I think most of us, we don't know, because we all worried about the acute cases. We don't know what's happening with these patients when they get discharged from the hospital, how to manage, what's the outcome. And I will probably give the floor to Dr. Farah to take it from here. Dr. Farah, you can start your talk, please.
Thank you so much, Noor, for the introduction. And thank you to the group, the administrating group, for inviting me to talk about this important topic. Assalamu alaikum, everybody who's on the webinar. As Nubhai said, my specialty is rehabilitation, so physical medicine and rehabilitation. What we do is marry the rehab part to the medical part, and improve outcomes in function and quality of life. As you all know, on January 31st, WHO declared a global emergency with this virus. The pandemic was declared in US on 11th of March. We know how this pandemic has changed our lives. Every aspect of our life has changed. From going to a wedding to going to buy groceries or even a walk. The first surge that happened in US, and most of my my information is around the US because that's where I'm working. The first surge was started in beginning of March, and we probably had the highest mortality rate in mid-May. This is the second surge that we are seeing even in our organization. Restarted again, the numbers are creeping up. I tend to see both the things. I see what is, how many people are being diagnosed or getting positive COVID tests. But for me, the more important thing is how many are getting hospitalized, because I tend to see these patients in the hospital. I tend to get consulted with on these patients. So my work around increases a lot more when the patients are hospitalized. You know, a lot of people ask me, how long do you think this will go for? I bet anybody can actually make a guess on that. But, you know, just looking at the scale of suffering, there is the Justinian plague back in the Byzantine era. It lasted 48 years. 48 years, that's how long it lasted. Hopefully this one is not going to last this long. The number of people who died in it were 50 million people. Black Death in 1349 lasted 5 years, 50 million people died. Spanish flu lasted 1 year. The source was pigs and 50 million people died. Asian flu 1957 lasted 1 year. That was your H2N2 influenza. The HIV/AIDS epidemic started in 81, still ongoing, 40 years, 32 people have passed away from this. That's the mortality rate. These are very fresh numbers that I got from National Geography that had just been released, that magazine. I thought that was interesting. So that kind of gives you an idea of how can we predict what's going to happen. But like some of the very interesting leaders have said, the health and the economic costs or the impact of this disease is going to be long. What we don't know how deep it will be. That's what we don't know. Oh gosh, okay, here we go. Okay, next slide is, we know this disease is not treatable. We don't even have a vaccine. Most of our treatment is around supportive measures. We don't know what the trajectory of the disease yet. It's an uncharted territory. The literature that is there is evolving. In addition, you take the political climate, especially in US, where we have this the Republican and the Democrat sides, which are extremes. And one side says the virus is just a cold and nothing will happen to me, and the other side that is so afraid of it. You add this kind of climate to it, you have a very good place for this virus to multiply. Also remember, in US, about 10,000 people turn 65 every day. So this is the demographic of the US population is aging rapidly. So we have a lot of people who are more than 65. Again, the virus is suffers, infects those people more who are more than 65. So again, the land is very fertile for a very bad outcome in US. What are we doing so far? We have about these are the total number of cases. You can probably see over here. The number of deaths is about 145,000. If you calculate it, it comes out to be about 3.5% mortality for this virus. Okay, but if you look at the number of people who are hospitalized and you look at the mortality rate in those patients, you will find that they are the number is quite high. This is what we have in Minnesota, which is where I am. It is only the county of Hennepin, so it's not completely in Minneapolis also. So we have about 16,000 people who have been confirmed to be COVID positive and 806 dead. This is in Hyderabad, India. Of course, I'll talk about that because that's my birthplace and that's home for me. We have 52,000 confirmed people, COVID positive patients, and 455. I'm not sure how reliable these numbers are, but this is what we have based on the Johns Hopkins website, which is a website that a lot of the physicians in US look at too. Okay. So what do we have? The data has been evolving. We don't know how things are going, but every organization, including the University of Minnesota, where I am at, is collecting biological and statistical data to determine what are we looking at, the scale of the problem. We know 81% of the people, of the patients who get positive COVID will only have a mild disease. They will not need to be admitted to hospital. 20% will get 19 to 20% will get admitted to the ICU. Overall mortality rate compared to the mild and the ICU is about 3.5. But if you look at hospitalized, that mortality rate goes up to 13.9. So much higher in those who are hospitalized. We know the most common cause of death in the ICU in our organization is ARDS and DIC, disseminated intravascular coagulation. Right? So you see, of the patients who are hospitalized, 32.8% of these patients will have ARDS. I have been asked many times that what makes a person be so severely impacted by the virus versus those who are not. Some of the literature shows diabetes, shows hypertension, people with chronic kidney disease. In my experience, what I'm seeing is what I call metabolic syndrome. So metabolic syndrome is a state prior to getting the diabetes, prior to getting the hypertension, where a patient is somewhat overweight, is somewhat sedentary lifestyle. And I see those patients quite a bit affected by the virus, and the impact the virus has on their health is far more severe compared to those who are far more healthy. Another one that I'm seeing is central obesity. By central obesity, I mean, if you look at these patients, they have pot belly, but if you look at their thighs and their legs and their arms, they're very thin compared to their abdomen. So this central obesity, I find, is very commonly seen, especially in those patients who are also quite active but have not really fine-tuned their health very much. In one of the studies that we are seeing, actually it is based on the United Health data. The people in US will know United Health is an insurance company over here, huge insurance company. And based on their data, we are finding that metformin is actually protective. And that again goes back to my original thought that central obesity and metabolic syndrome patients tend to have a higher severity of this disease. We know the disease is not treated, but the conservative measures are IV fluids, intravenous antibiotics, not for just empirically, but for suspected bacterial co-infections. We were talking about intubation, ventilation. We also have in our organization ECMO, which is extracorporeal membrane oxygenation. In these cases, the lung is so severely affected by ARDS that even intubation cannot help these patients. So we just take the lungs out of the equation. They are being oxygenated by the ECMO, as it is called, outside their body. We haven't had a whole lot, many patients to do that with, but we have had some. Initially, I remember when I was seeing these patients, the ventilation strategies were quite different compared to what we are doing right now. We are not going very high with our tidal volumes and inspiratory pressures and so on. Prone position to reduce mechanical injury to the lung is also very important. And then the extracorporeal membrane oxygenation that I talked about. What are some of the complications that I see? I'm seeing acute kidney injury, definitely, actually very, very common among the patients that I see coming out of the ICU. Many of these patients are on dialysis. And alhamdulillah, what happens with time is that these patients also will get off their dialysis with time. I do see improvement in their creatinine levels as well. That poses a different challenge to the system when you're trying to discharge a COVID positive patient who has dialysis needs, because not too many dialysis centers want COVID-19 patients. So you can imagine the challenge around it. Acute liver injury, we are seeing steatosis in these patients. At least the least I'm seeing is increase in their liver function test, which needs to be monitored as they go along in their disease. Septicemia, stroke, DIC, hematomas. Do see a lot of hematomas in these patients. And when I say hematomas, I mean just simple bleed in their muscles. I've seen patients with bleed in their quads, bleed in their biceps. And this affects the way they walk and how independent they can be afterwards. So when I look at the complications or the comorbidities, as a rehab doctor, I'm looking at those things that will affect the way this person thinks, walks, anything that will make him stop him from going back to work, or the life that he led prior to this injury. Of course, cardiac injury is also one of them. Neuromuscular complications are many, and these are very close to my heart because, again, they affect how a person will conduct themselves. Will they be able to walk? Will they be able to do their activities of daily living? How much burden of care will they require following discharge? So I divided them into three parts. One is the central nervous system. What I do see is impaired balance, headaches, impaired consciousness. Delirium is very, very common in my ICU patients. What I do see in these patients with delirium is that when they wake up, when they are extubated and they wake up, they might have been intubated for 2 weeks to even 6 weeks, what I have seen. Which are unprecedented numbers, if you ask me. I've never seen intubations as long as 6 weeks prior to this time. So when these patients wake up, they are not just delirious, they are agitated, they're confused. Imagine being in a room where everybody comes in with a PPE. They do not have visitor rights. So none of their family members are there. So they are in a room where people are coming in looking like probably aliens to them. And you can imagine what happens to these patients. Significant amount of agitation. However, they do get better. But what happens later on is that they do develop cognitive impairment. Other things are stroke because of the DIC. We definitely see stroke. So these patients will be extubated, wake up, and we suddenly find they have right hemiparesis or any of the other symptoms of stroke. Excuse me. Other things are seizures, ataxia. Some of the common symptoms of presentation is loss of smell and taste. and vision. And what we are finding is that there is retrograde migration of the virus into the brain through these cells. Seeing a lot of peripheral neuropathy too. We do have skeletal muscle injury, and I'll talk a lot more about it towards the end of my lecture as we talk about rehabilitation. When I see these patients, I'm dividing them into two parts. One is those who got intubated and those who did not get intubated, because I find their rehabilitation costs quite different. Those who are intubated, they are so affected by the immune response that they throw in response to the virus being in their body. It affects every aspect of their organs. Higher levels of creatine kinase, lactate dehydrogenase, severe muscle atrophy, ventilation dependency, anxiety, PTSD, cognitive deficits. Those who are not intubated and maybe discharged earlier, I find significant fatigue. And this is, I'm a stroke rehabilitation doctor. My specialty is in stroke. So I'm used to seeing post-stroke fatigue, but this is so severe and so prolonged, it is quite impressive. I wanted to talk to you a little bit about ARDS because it does affect what will happen to your patients when you follow them for long term. We know there is ICU acquired weakness. That's very common, right? Based on whichever study you want to look at, there are the incidence of weakness following the ICU admission for ARDS. It can be anywhere from 25% to 100%. Many reasons for that. One is patients are paralyzed and intubated, they're immobile. Glycemic control is another one, use of steroids, which causes steroid myopathy, remember? Now we are also using neuromuscular blocking agents in these patients, especially because we keep them prone. Can you imagine a patient who's intubated and being prone? They get very agitated, so even higher dosages of neuromuscular blocking agents are employed on these patients to keep them calm. But not only just these, but more unique to the COVID-19 population is the immune response and the virus itself. We know from ARDS that even at 5 years after extubation, these patients have fibrotic changes in their lungs because of the ventilator-induced injury. So you can imagine if these patients are discharged home and they're not able to walk, and if they walk, they get breathless and hence they don't want to walk, what will happen 2 years, 3 years down the road? What will happen to their ability to take care of themselves or to be able to walk or have a quality of life? We also know that we get muscular weakness from the ICU, critical care illness, myopathy, we have peripheral neuropathy, cardiorespiratory deconditioning. There is postural instability, and what happens is the body loses its ability to pump the blood up into their brain. So they get a lot of almost like an orthostatic blood pressures, but sometimes they don't even show orthostatic blood pressures. They have good volumes, fluid volumes, but they have this postural instability because of the loss of the reflexes that allows this to happen. Muscle shortening, very, very important, because imagine if I'm seeing patients who were intubated for 6 weeks at a go, and their muscles shorten if they were not being stretched. And then they stand up and they're not able to stand up anymore. Contractures, pressure ulcers. So those are some of the things. The thing that intrigues me a lot is the cognitive impairment. We know from our studies on ARDS that 80% of the population will have cognitive impairment. And we also know 10% of these patients will have persistent, irreversible, long-term cognitive impairment. If our patients with COVID-19 are patients who are younger, in 40s or 30s, you can imagine what will happen to their livelihood because of these cognitive impairments. What do we see? What kind of impairment we see? We see impairment in short-term memory, attention, executive functioning. All these are things that are required for you to go back to work. These makes the treatment challenging, and best approach is to prevent it. So what are the preventions? So the Society of Critical Care Medicine recommends these measures to prevent delirium, assess, prevent, and manage pain. And by that, of having a good balance of what kind of narcotics you're giving them, what kind of painkillers you're giving them. So finding that fine balance where they're awake and alert and active, as well as not in pain. So not going the either way. Spontaneous awakening and breathing exercises, a choice of sedation is very important. Monitoring of the delirium and management. Certain medications are not that good. As a PM&R doctor and somebody who does see a lot of patients with traumatic brain injury, I prefer not to use Haldol, which is very commonly used in agitation and delirium. I tend to use more of Seroquel. Early mobilization and exercise, there are plenty of studies. There's one study, Everett 1, that shows the faster you can get your patients out of the bed and make them walk, the better they will be long-term. Family engagement and empowerment. Psychological effects, psychiatric complications, anxiety, PTSD, depression, high levels of emotional stress in the pandemic. I think we talked a little bit about that before, so I won't go for it further. Throughout the U.S. and particularly in my organization and wearing my administrative hat, there are many levels of care that we provide. So we have the acute rehab unit facilities. Now you'll say, what is this? And these are facilities that are so regulated by Medicare and Medicaid requirements that they have a very fine line of who can be admitted and who cannot be. These are units, inpatient units. They're part of the hospital. The rehab doctors, intensivists, hospitalists all rotate here. We have access to every specialty possible. It's not a nursing home by any means. Very, very expensive. So that's why CMS has very high regulations as to who we can admit there. 3 hours of therapy. The nurses who work here have to be certified in rehabilitation in addition to being a nurse. The difference is a nurse on a regular hospital floor may actually do the work for the patient. They may help the patient get up. They may help the patient get dressed or move. But a rehab certified nurse will not do that. Her job is to stay back and look for red flags or warning signs of safety issues. But otherwise, she will actually push the patient to be more independent. So it's just a change in the way you are managing these patients. That's your acute rehab units. 3 hours of therapy is mandatory for the patients admitted over here. If somebody cannot participate in 3 hours of therapy, they cannot be in acute rehab unit. The other one is nursing homes and transitional care units. These are your basically nursing homes. People go there, maybe they have an hour of therapy. If they refuse, nobody's going to ask them. So a much lower level of therapy over there. Long-term care units are more of, patients with very high skilled nursing needs. Those who have a tracheostomy, those who have PEG tubes, and so on and so forth. And so they go there, but not a whole lot of rehab needs, somewhat. HEP is home exercise program. Home therapy is somebody goes to the patient's houses to do therapies. This is what we were doing mostly during the pandemic, wearing the PPEs. We were sending out our therapists to people's homes to have them do physical and occupational therapy as well as speech therapy. Outpatient therapies were actually canceled entirely during the month of March and April, as well as partial May. We were, as an administrator, I actually had most of my 60% of my therapists on furlough. A lot of position cuts went out because of the outpatient therapy that could not be done. And finally, pulmonary rehab. Many of our patients will get pulmonary rehab. We talked about this already. I'm going to move on. Or am I going back? Yeah. Okay. I'm going to talk about, to give you an idea of what I do and how you can implement rehabilitation strategies for your patients. I'm going to talk more about certain patients. Rick Higgins is actually my patient, and he was on TV, and because of him, I was asked to talk about him as well, which is why I'm able to use his name, as he was already on media. He's a 51-year-old gentleman. He's a biker. He bikes about 40 to 50 miles easily. He had no past medical history of diabetes or hypertension. if you looked at him, he was your perfect, very athletic guy. The only thing I see in him was mild central obesity is what I see. He was admitted for COVID-19 and was intubated for, and intubated for about 4 weeks. During this time, he lost 30 pounds. Most of it was muscles. The atrophy that I saw in him on examination was just incredible. He had a hematoma in one of his quadratus femoris that prevented him from walking properly. So he was dragging one foot because he just could not flex that leg. At the time of discharge from the acute hospital, he was unable to walk. He was on 4 liters of oxygen when he came to the acute rehab unit. He was there for about 7 to 10 days and he walked home, not on oxygen. So good recovery. Here is another patient. This is a fictitious name, as this patient is has not been on the social media. He's 51 years old. Again, independent prior to this. He was a respiratory therapist by his job. He was admitted and he was intubated for 53 days. And this is a very unique case because I've not seen anything like this. The atrophy of his muscles was so tremendous. He was all bones. He had lost, I believe he had lost 40 pounds. Most of it was muscles. The atrophy that I saw was not only throughout his extremities, but I see facial atrophy, which is very unique. I don't see facial atrophy that often. And he could not speak. He was hypophonic. He had paralysis of his vocal cords. He had facial muscle atrophy, severe muscle atrophy. He had peripheral neuropathies, and he had bilateral wrist drops from, and I don't know if that is because of the involvement of the COVID-19 or was it because of the intubation. I don't know about that. And only literature onwards will tell us about that. So he's still in the ARU right now. He has not been discharged. He's working hard. We're finding, therapists are finding every kind of brace to help him keep those wrists up so that he can use his finger flexion to do as much as he can and become independent. But that's him. Bevan, I used him, this is his actual name, and he was in the newspaper too. That's why I used his name. And he's our CEO of the University of Minnesota Physicians. He is an ENT by background. Fairly independent guy. He went to work every day, ran through the hospitals, seeing patients just like we all do. Maybe overweight by 15 to 20 pounds, maybe not as much. I mean, I don't think he was going to the gym or going for walks. He was admitted for about 1 week with COVID-19 symptoms. He did not require to be intubated. He's a very different case, and that's why I brought him here. The amount of fatigue that I see in him and the mental fog that he experienced. For 2 weeks after discharge from the hospital, he could not come back to work because of that mental fog. He's back to work now. He's 3 months after. He still has not achieved his premorbid level of functioning. Means he's not able to do many of the things he was doing before, which is running from point A to point B to see a patient or not. I don't know about his cognitive impairment. I don't think anybody has tested. I don't think he wants to be tested. But again, that is just the kind of issues we are dealing with this patient. So going back to general principles of rehabilitation, for those who don't know what functional homeostasis is, it's a very interesting term that we use in our rehabilitation world. Functional homeostasis is your ability to bounce back to your baseline following admission of any kind. So for instance, a 16-year-old boy who comes to the hospital to get an appendectomy goes back home, maybe has some pain, but he's going to bounce back to his own level of functioning and be able to run and walk fairly quickly. But if you have a 65-year-old, maybe they have history of a heart attack, maybe an EF of about 35%. They come to the hospital, they get admitted even for a pneumonia, and they go back home. You will suddenly find that they cannot do as much as they could do before. So you admit these patients several times, maybe in the next 3 years, suddenly this patient is not going to get out of the bed. So suddenly you have a bed-bound parent. How do we prevent that from happening? A lot of it is got to do with cultures. Because when I see my Somali patients in my acute rehab unit, it's most of the time it is that, oh, you know what, my son will take care of me. He'll help me get out of bed. Why do I need to do this? But you're not helping your parents, your elderly, by helping them physically. You got to let them do it. These are the cultural barriers that we come across. Proximal muscle
We have
weakness
5 minutes,
is very,
Dr.
very
Farah.
important. How many minutes?
5 minutes, yes, please.
Okay. Yeah, I'm almost done. Pulmonary aerobics, very, very important. And when you are managing these, how much you're pushing these patients. I mean, are you going to tell your patients go and walk for a mile, or are you going to tell them go and walk with someone for about 10 minutes and come back? All that depends on what are they doing medically. What is their ejection fraction? What is their oxygen levels? What kind of arthritis, back pain, other comorbidities, COPD that affects them. This is one of the last slides that I think is quite busy here. But some of the things I want you to take away from here is if you don't use it, you lose it. That's the general idea of how you function. Skeletal function, if you don't use it, goes from aerobic environment to anaerobic environment. What happens is lactic acid levels of production locally within the muscle increases, and that causes certain changes at a cellular level. At a cellular level, your type A muscle fibers turn to type B muscle fibers. Is this reversible? Yes, it is. The type B fibers fatigue easily. They cannot work for too long, okay? They have fewer mitochondria. Type 2A fibers are resistant to fatigue. They have a lot of mitochondria, lot of capillary, because these are your heroes of hard work. So what do you do for these patients? So I kind of take a look at pulmonary rehabilitation and add some components of that pulmonary rehab to what you should do to these patients to get them better. So teach them the benefits of daily exercise, daily walk, always pushing them beyond their comfort zone. Pursed lip breathing, because if they have been intubated or they have been affected by COVID-19 in the lungs, you have to improve the lung health, and that you do it by pursed lip breathing. It allows peripheral alveoli to open, strengthening of the diaphragm muscles, and strength training. Don't go with here's 100 pounds and let's start trying to be Arnold Schwarzenegger. We're talking about 5 pounds, starting with 3 pounds, starting with 5 pounds, and going ahead with that. This is actually the yellow one, that these points that I have in yellow are the points that will allow you to change your type B fibers to type A fibers and improve your longevity. That's all I have for today. I'm open to questions if you had.
Thank you very much for an enlightening talk on such an important topic, which we normally overlook, but it's very important, especially people getting discharged from ICU. And we, in our own practice, we have seen a lot of patients with disused muscle atrophy and peroneal injuries, foot drops, and this is where people like Dr. Farah's expertise come into picture. So roughly how many months do you give these patients to recover, like 3 months, 4 months? What's the recovery period window for these patients?
Depending again on how long they were intubated or not intubated at all, I would start with at least 3 months and go beyond that. And we do not have enough literature right now on COVID-19 to actually predict how long exactly I need. I would start at least with 3 months.
So in your current clinical practice, what sort of volume do you have in your center at the moment with these patients, long term?
Interesting. We went very high volumes. We've come down now and we are going back up again. In our ICU, I think, and this is supposed to be, we're not supposed to indulge this information, but I would say we have about 3 ICUs right now that are open.
Wow, that's a big number actually.
Yeah, quite a big number.
Thank you very much, Dr. Ikram. Again, thank you very much for taking your time out. So moving on to the second speaker.
One question for Dr. Farah.
Yes.
We have seen many patients, being a pulmonologist, we have seen many patients discharged with the diffuse bronchial appearance, and patients need oxygen. Mostly patients, they are improving after 3 months. So they're going almost to, some patients might have some therapeutic changes and they may improve after 3 months. What is your experience in these cases?
My experience in this is that if you, their oxygen levels are good at a certain level of functioning, but you have to push these patients beyond that level of comfort. For instance, when one of our first patients who came from our specialized unit, that is COVID-19, to our rehab unit, the patient did not have any oxygen needs, because when the therapist monitored his oxygen levels in the room, he was walking about 10 feet. When he came to our unit, he was at the basement. He took the elevator and came upstairs and almost was so dyspneic that his O2 sats were in early 80s, and he was almost lightheaded because he had not walked that much. So you have to keep pushing these patients beyond their comfort zone.
Thank you so much.
So Dr. Ubaid, can we proceed for the second speaker?
Yeah.
So it's a pleasure to introduce the second speaker, also Dr. Fawzia Jabin. She is an alumni from Deccan Medical College. She's trained in England. She did a master's in micro. Thereafter, she did a structured training program in clinical microbiology and virology, and has worked as a consultant in University of Nottingham, which is a Robin Hood country. Before then, she moved to Middle East, Abu Dhabi. She's currently working as a clinical lead at Sheikh Khalifa Medical City, which is a regional center for COVID in Emirates of Abu Dhabi. So it's an honor to have Dr. Jabin on board with us. So Dr. Jabin, the floor is for you. You can share your screen and start the talk.
Thank you so much for giving me the opportunity to present today. Today I will be talking to you about the diagnostic aspect of COVID-19. We will touch briefly on the virus and its many relatives that are circulating at the moment. We will talk about the pathophysiology briefly, and then we will concentrate on the diagnostic aspects, including the sample types, the methods, and the limitations of each test. We will very briefly go through the newer developments towards the end, if time allows. So as you may have heard many times in many presentations, coronavirus, it was initially known as the 2019 novel coronavirus. Then it evolved to be the COVID-19 or the SARS-CoV-2, which is what it is referred to in most scientific literature. It gets its name from the Latin word corona, which stands for crown or wreath, which refers to its appearance on electron microscopy, where the bulbous surface projections give it the appearance of a crown. That's just a computer representation of the virus. It belongs to the beta coronavirus. It's an enveloped virus. And being enveloped actually makes it even more vulnerable to disinfectants. So actually that is a plus, if there are any pluses with COVID-19. It's a single standard RNA virus, and it belongs to the subfamily orthocoronavirus, subgenus SARS-CoV-virus. It's not the first zoonotic coronavirus to emerge and cause havoc in humans. It's the third, actually, and it's one of several others that cause just common cold in human beings. Humans are not the only hosts. It also infects animals, bats, pangolins, chicken, pigs, cows. And in the latter two, it actually does cause symptoms as well. And there's always the hunt to find out where it originated. The bats are usually the targets of all emerging new coronaviruses, and bats seem to be the petri dish of all sorts of viruses brewing there. This is a picture of the SARS-CoV-2 replicating in an alveolar cell. And this is the viruses budding out of the cell after replication. No viral talk or microbiology talk is complete without a phylogenetic tree when you're talking about viruses. And this is literally a family tree of viruses. And as you can see, the coronavirus is a beta coronavirus. It is very closely related to the SARS-CoV, which we have known to cause outbreaks in the past. It is also closely related to the coronavirus OC43 that does circulate in the human population every now and then. This is of particular importance when we talk about diagnostics, because when we are looking into serology, there can be cross reactions between these coronaviruses. So something to bear in mind. It is also quite closely related to the other commonly circulating coronaviruses in humans, the NL63 and 229E. These are predominantly circulating in the pediatric population and is known to cause mild respiratory illness. And as you can see here, it is also very closely related to a bat coronaviruses that we know infect bats of different varieties. This is just another phylogenetic tree which gives a bit more detail, as you can see, this is where the Wuhan coronavirus or the SARS-CoV-2 is. And it is very, very closely related to the bat SARS coronavirus, and that is where the origins seem to be. In terms of coronaviruses or zoonotic coronaviruses that have infected humans, it is not the first, as mentioned before. SARS-CoV-2 has been on the radar for a long time now, and the transmissibility potential is measured as a basic reproductive number, or R0. This just gives you an idea of how easily transmissible a virus is, and the number of expected cases that will be generated from a single case. So as you can see, when it was MERS-CoV, which came up not so far in the recent past, the transmissibility was only 0.5 to 1. And compare that to the current virus, the SARS-CoV-2, that's 1.8 to 3.6. And that explains the large scale of transmission and infection that we are seeing today. It is often compared, when we learn from history, it is often compared to the 1918 influenza pandemic, where again, the transmissibility was quite high, and globally, the influenza pandemic had caused a huge mortality and morbidity. And talking about mortality, the case fatality rate, it depends on what literature you're reading. So even until this month, the number quoted is 2.3% overall. Having said that, it depends on the demographics of the population and how much of a high-risk population is there in each country. And that explains the higher mortality seen in some of the countries as exposed to countries like the UAE, where the mortality is not that high. Compare that to the SARS and MERS-CoV-2, where their mortality or the case fatality was 10% and 34.4% respectively. Again, MERS-CoV was targeting the elderly, the ones with comorbidities, so patients who were at risk were pretty similar to the ones we see now, whilst the fatality was seen predominantly in the at-risk population with MERS-CoV. And we are seeing fatality with SARS-CoV-2 even in the healthy population. I'm a virologist. I like to dissect viruses, but not just for the interest, but also because it is relevant in terms of diagnostics. SARS-CoV-2 obviously has this spike protein, which gives it its appearance, but also it is a very important protein when you talk about diagnostics, because the antigen assays and the PCR assays are actually targeting, to a large extent, the spike protein. Within the spike protein is the S1 and S2 subunit. It is important to know that because these subunits are the more conserved units. And when I say conserved units, you have to bear in mind all RNA viruses are subject to replication and mutation. This is part of the natural life cycle of an RNA virus. When you talk about mutation, you have to bear in mind that PCRs or PCR assays target the genomic sequence of these subunits or the spike subunits. And if you start seeing that the building blocks are moving or changing, then the PCR might not work. So it is very important when we design PCRs to go for a part of the virus which is conserved and not subject to mutation. And when we talk about diagnostics, it's important to bear in mind the different stages of infection or stages of disease, whereby the virus is seen to be replicating in certain parts of the body and is more likely to be picked up on swabbing or sampling. So in this first stage of infection, which is the asymptomatic first 2 days of infection, the virus is actually targeting the ACE2 receptors. There's local propagation of the virus, and because this is just confined to within the cells of the nasopharynx, it is not really exposed to the body's immune system, and therefore there's a very limited innate immune response. However, if you were to do a nasopharyngeal swab at this point, you're more likely to pick it up on this nasopharyngeal swab. And this is where the infectious super spreaders seem to have an ongoing and high replication of virus, and that's how spread occurs when we talk about super spreaders. I put this slide in the middle just to remind ourselves of the different immunological reactions we see in the face of triggers such as viruses or bacteria, where a person has a genetic predisposition to a hyperresponse. You have a high level of inflammatory cytokines being produced on trigger by the virus. You have the IL-6, IL-18, TNF-alpha, and of course an increased T cell activation and expansion. And all this is harvested in the diagnostic aspect. We then move on to the stage 2, which is the upper airway and conducting airway response, where there is migration of the virus to the conducting airways. So as the disease progresses, the virus moves from the nasopharynx down to the lower respiratory tract. Here, the innate immune response is triggered, and you will see all the IL-6 and all the other inflammatory markers rising. You see the patients manifesting with the classical symptoms. And here, if you were to take a nasal swab, or if you were to take a sputum sample, you're more likely to recover the virus in terms of sample types and diagnostics. And I won't go too much into the detail of the inflammatory markers that are measured and that are now also known to be prognostic in some ways. So this is the point at which we would see that the response coming up, and the measuring these at this point is of benefit. In 80% of the cases, this is restricted to this upper and conducting airway and conductive airways, and the patient improves, and it is mild and is restricted. In 20%, it does progress to ARDS, which my colleague previously has talked about, where the virus reaches and propagates into the alveolar type 2 cells, and there's a high viral load of virus particles in the lower respiratory tract. It not only is the virus that is causing the disease or pathogenesis, but also the healing process, which involves a lot of scarring and fibrosis, which all has a bearing in the outcome. Now, the respiratory system is not the only system involved, as we are seeing, and increasingly there is evidence that in children and in immunocompromised patients, it's not just their respiratory system, but also the central nervous system and other symptoms in the systems involved. So you see thrombocytopenia, neutrophilia, lymphopenia being developing in these patients. We have seen our share of myocarditis and also gastrointestinal symptoms. So what are the different diagnostic methods we have to detect this virus? I mean, the first publication that came out describing the virus, talking about the virus, actually was following the electron microscopy and growth of this virus from the first case. So this is what the virus looks like on electron microscopy. As you can see, this is the virus on electron microscopy, and this is in the epithelial cells. Now, growing the virus is not new to just SARS-CoV-2. We have seen that the previous SARS-CoV also grew very readily in the Vero E6 cells, and this was employed in growing this virus. And the culture it is not a quick process growing the virus. It is cumbersome. It takes a long time, up to weeks, if not days. And it is very dependent on the skill of the person reading these cell cultures. So this is not routinely used in the diagnostic aspect. Having said that, we are, as a lab, looking into employing this modality for patients who are in ICU, who have PCR positive for ages. For months, they will be PCR positive. So what we are then doing is we are taking these samples of the PCR positive patients and inoculating them in cell cultures to see if this is viable virus or is this dead virus. If it is viable, it would grow in cell cultures and we are able to detect that. Of course, this is also important in the vaccine, in calculating the effectiveness of vaccines or the effectiveness of plasma being used for treatment of patients. This is just a picture of the cell Vero6 cells. These are healthy cells, and this is what the virus does to these cells after a certain period where you start seeing the cytopathic effect. This is just another example where the virus, this is a healthy epithelial cell culture of human airways. And this is after infection with the virus. I don't know if that is very clear, but you do see a cytopathic effect even in that cell line. This is a diagrammatic representation of a plaque neutralization assay, which relies on growing the virus as well, again, of use when we are looking into convalescent plasma evaluation or vaccine evaluation, where virus is growing on cell culture, cell patches, which is shown as plaques here. And once the neutralizing antibodies or antivirals act on these viruses, you can see the plaque number reduces. In real life, this is how it looks. And as you can see, this is where the virus is growing happily. And this is after a dilution. And as you can see, the plaque numbers go down. These 1 in 10, 1 in 40, 1 in 60, this just depicts the dilutions of the patient serum. This is a useful diagnostic modality for when we are studying the impact of convalescent plasma or antivirals, as I said. Here you can see the number of plaques reducing after the use of the convalescent serum. This diagrammatic representation of polymerase chain reaction, or PCR, which is the cornerstone of diagnosis for COVID-19. Just to go through the principle of the test, one or a single DNA or RNA copy is multiplied by these target primers, and with each cycle, because polymerase chain reaction involves cycling temperatures and cycles, with each cycle, you see the doubling of the numbers. In RNA viruses, there's an extra step, which is the RNA polymerase. So there is a reverse transcriptase, which turns the RNA virus to a DNA, which then is multiplying into amplicons with each cycle, and that's what's detected. Another diagrammatic representation of a negative sample, a low viral load where 1 or 2 copies only have been multiplied and you can still detect it, or a high viral load where there's a lot of virus to start with, and within cycle 2 you start to see a lot of amplicons. And this is how it is depicted as cycle threshold. So somebody who has a high amount of virus would be detectable just within a few cycles of replication, while somebody who had even just 1 or 2 viral particles to start with would take a bit longer to amplify it, and you would detect it at 30 cycles. I know there was a text message flying around that said, oh, it is now mandatory to report the cycle thresholds when people are reporting PCR results. This is not an absolute science, but it does give a sort of ballpark figure or a feel of where we are in terms of the viral load to start with. It is particularly useful when we are monitoring the same patient. So if to start with, on the initial phase of infection, the cycle threshold was 10 or 17, and then 3-4 weeks later, you see the PCR is still positive, but the cycle threshold has gone up to 32 or 40, then you know that actually the viral load is going down. This is more standardized in real-time quantitative assays. Unfortunately for our PCR at the moment, for all coronavirus PCRs that are available, they're all semi-quantitative, they are not quantitative. So you have to take this with a pinch of salt. I know I keep going on about the structure of the virus, but it is of importance when we talk about PCR, because a lot of PCRs are targeting certain areas of the virus genome for detection. There is the spike protein, the envelope, the membrane, and then there, of course, there are the RNA or the RNA-dependent RNA polymerase, which is one of the targets of PCR. This slide gives you an idea of the different diagnostic assays available in the market and what the target areas are. And as you can see, most of these PCR assays have more than one target. There is a reason for that. It's because having more than one target will give you a more confidence that this is just, it's not just any coronavirus, but SARS-CoV-2. Because if you look at the genome of SARS-CoV-2, it is very similar to the other SARS-CoV and the other coronaviruses. So having more than one target increases the specificity of the PCR. The PCR sample type, as you all know, the first and foremost sample to be collected is nasopharyngeal or oropharyngeal swabs. And we know from literature that actually this is the best sample to take. The recovery of the virus is best from this sample type. But you have to bear in mind that if you have somebody who has already been through the early phases of the disease, is already in ARDS, we do have our share of false negative nasopharyngeal, oropharyngeal swabs for good reason, as explained previously. It's because the virus is now down in the lower respiratory tract and replicating happily in the lower tract. So in these circumstances, a bronchoalveolar lavage or a sputum sample is ideal. We see that actually the virus replicates in the gut enterocytes as well. So there's a lot of studies now looking into detecting the virus in stool, which is so much easier to get and seems to be promising. So we see that 2/3 of the patients who had coronavirus infection had detectable RNA in stool as well. There's also studies going about anal swabs. How about other samples like blood or CSF? There's only a few studies that have looked into patients that present with central nervous system involvement and whether the CSF will have detectable RNA, and actually there isn't any promising evidence that there is, it is indeed a useful sample to test. The best thing to do would still be a nasopharyngeal swab. There is viremia is described in these patients. So you do see detectable RNA in blood. And that tends to be for 2 to 3 weeks. So it is not that perfect. The RT-PCR has its own limitations. There are false negatives and there are false positives. And this was seen increasingly in asymptomatic patients where because they were close contacts of confirmed cases, we started seeing all sorts of spectrum of results from these cases where you would find a completely asymptomatic patient giving a high PCR positivity and the other way around as well. This is a good study that came out last month that described the dynamics of the virus or the RNA by PCR. And as you can see, high levels of positive PCR results are seen towards the early part of the disease. So these are represented by the red bars, and then you see the negative PCRs coming up towards day 16 and beyond. And these are the false negatives because these are patients who are actually infected. So the PCR is useful in the first couple of weeks. This is just another diagram that shows the distribution of the PCR positivity and plotted against the days after onset of symptoms. The study looked into relating the age or other demographics and its impact on the positivity with PCR. And the only one that was statistically significant was they tended to have a PCR positive in those who were greater than 65 years of age. And that tended to be there for a long time. So we did see that 30% of the patients with 2 consecutive negative results were turning positive. And after 4 weeks, 26.3% of the samples were remaining to be positive, even though the patient was improving. So what are the factors that contribute to the false positive or negatives? There's a lot of factors. There's pre-analytical, depends on what sort of sample you have sent, how the sample has been handled, transported, how the reagents or the actual test is regulated, and the validation of the assay. Is it a robust assay to start with? And how is it the quality of the assay assured? This is all to do with the laboratory side, and a lot of times this is not something that comes out. You must have heard in the news that there are independent inspections of laboratories now because of the high positivity rate. Is this really real, or is this due to contamination, or is this due to other factors? So this needs to be very tightly regulated, and it is proving to be a challenge. Serological assays. When we talk about serology, you have to bear in mind these diagrams where you see when exactly do we see the immunological responses. And unlike the PCRs, the serological response comes up much later. So you start seeing the IgM coming up later. So about day 7, you start seeing, and it peaks about day 14. And then it disappears by day 21 to 28. And then the IgG comes up, and it tends to remain positive for a long time, but we don't know how long that is. In some patients, we see that even the IgG starts to decline. And that is of consequence when we are talking about convalescent plasma being used. So ideally, if a patient is within the first month of having had the infection, then there is hope of harvesting enough antibodies. After that period, it does start to decline. So antigen tests are out there, and antibodies. Antigen tests directly detect the presence of the viral protein or the spike protein, which is the usual antigen we see in the commercially available assays. And then, of course, the antibody assays, which talk about the different coronavirus proteins. And these proteins, again, are not confined to just SARS-CoV-2. There's a whole lot of coronaviruses that also possess the same proteins, and therefore there's a potential of cross-reaction in these assays.
5 minutes.
Okay, so this is just a depiction of enzyme immuno. This is signal being read, and this is how it looks in the lab, the different colorimetric strength that is recorded as a result. This is another diagrammatic representation of the lateral flow immunoassays that we are increasingly seeing out in the market, whereby antibodies are detected, either the IgM or the IgG, as a change in color in the band. This is what it looks like in real life. This also has a limitation, as we said earlier. So first, the antibodies are not produced in the initial part of the disease. It is not a very good modality for immunocompromised patients or patients who have some genetic abnormalities, whereby the antibody response is not optimal. This is a study in the BMJ this month that talks about the different antibody assays, the enzyme linked, the lateral flow, and the chemiluminescent assays. And the different, as you can see, the sensitivity and the specificity of these antibody assays is not great. So only 66% for the lateral flow immunoassays in terms of positive predictive value, and 34% could be false positive, and that's really not optimal at all. So this is just another diagram that shows the false negativity. The false negatives for RT-PCR is later during the disease, whilst the false negative of serological assays is early towards it. So which test is the best? It depends on where the patient is in terms of his own symptomatology, the patient population to be tested, the technical abilities. So the negative result of PCR is not for ruling it out, but a positive test does rule it in. And the other way around for the antibodies, where a negative result could be used for ruling it out, whilst especially towards the later part of the disease. And there are several ways of overcoming these limitations. It's using a combination of clinical evidence, the laboratory diagnostic parameters, to be able to arrive at a diagnosis. This is just a table that tells you how you can combine the different modalities and come to a conclusion. So if it was just PCR positive, well, yes, this is early part of the disease and therefore this patient has got infection. If you find both the PCR and the IgM, you know this is towards the middle part. And then towards the end, you find that the patient will have an IgM and IgG, or either both or just an IgG, which will represent a past infection. There is a drive for newer, faster tests. There is now this new laser test that has been introduced in the UAE that doesn't necessarily depend on the DNA of the virus, but actually looks at the cell morphology, the red cell morphology, and how that changes in the face of infection, and that is measured by laser. And that's literally within minutes that you get the result. As you're sitting in the car, you get the result.
Okay, concluding remarks, please.
Okay, so very quickly going through the genomics, there's a whole lot of work being done in on the genomics side where mutations are being studied, and the study of these mutations is used in a lot of different, has different applications, not just in terms of whether these mutations have any clinical implications, but also where this virus has been traveling. In certain countries, certain strains have been circulating, and all that is being studied with genomics and bioinformatics. I think I will have to skip a few slides. So in summary, depends on which stage the patient is, that we need to decide what modality to use. Often a combination is helpful. And these slides just show you where, in terms of the symptomatology, the diagnostic modalities will be helpful. This is a summary slide that tells you that 20% of the patients can have a negative PCR or an antigen assay, and therefore you cannot rule it out with the negative PCR. You have to use different modalities. Also, persistent positive PCR doesn't mean this patient is persistently infected and therefore should have symptoms. A lot of times this is just dead virus or RNA fragments that are being detected by PCR. If in doubt, just call the lab and they'll be able to guide you. Thank you.
Thank you very much, Dr. Jibi, and thanks for simplifying such a difficult and confusing aspect of the COVID-19 viral serology and RT-PCR. I now open the floor, the panel for discussion. We have quite a few eminent members, physicians, and they're all. Can I ask Dr. Ubaid to introduce some of the panelists to the group, please?
Yeah. Assalamu alaikum. I welcome Dr. Matiuddin Salim. He's my teacher, a respectful teacher. Of course, I learn a lot from him. He's a senior pulmonologist of the city, I can say, and most experienced pulmonologist, working in many corporate sectors, corporate hospitals before. Presently, I think he's attached to the Care Hospital, Gachibowli, and also Sunshine Hospital. So even I worked him before, almost 15 years before. Still, I remember his talent, his dedication, his idea of approach to patient. I appreciate his definitely his invitation to join us. So I welcome Dr. Salim, Matiuddin Salim.
Assalamu alaikum wa rahmatullahi wa barakatuh. In fact, presently I am practicing as a chief consultant pulmonologist in Sunshine Group of Hospitals in Hyderabad, and also I am professor and head of the Department of Pulmonary Medicine in Kamini Institute of Medical Sciences. Welcome, Dr.
Matiuddin Salim. We have another member in the panel is Dr. Ehrar Ahmed. He is a professor of internal medicine at OSC Group of Hospitals. Is also consultant at Virinchi Hospital. Dr. Ehrar, welcome on board. Are you still there, or he drifted off from the long talk? And we have Dr. Parvez, American Board Internal Medicine physician, and also we have Dr. Najib, Dr. Fatima, intensivist, Dr. Yadullah Sayed, intensivist, joining us from Saudi Arabia, and myself, Dr. Noor, intervention cardiologist, joining from Abu Dhabi. So can I start with asking Dr. Parvez to start with his experience of dealing with COVID-19 viral testing and implication, how things are being happening in the city at the moment.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for giving me the opportunity today. I thank all the organizers. So the question is regarding the testing, that how the testings are getting done. Alhamdulillah, over the last few weeks, the number of tests which are getting done daily have significantly improved, increased in last 2 months. We are seeing a lot of patients getting RT-PCR test. Previously, until May, it was very difficult to get a person to get tested for RT-PCR, and now after for last couple of months, actually starting June, the number of tests in the private labs have increased significantly, along with the government, and we started using some surveillance tests for antigen and antibody testing, which are at this time they're not that great, but even today the RT-PCR has been the gold standard test, especially for the patients receiving treatment at the government facility, or for acquiring the important drugs for COVID-19 treatment like remdesivir or tocilizumab. The government has made mandatory for the RT-PCR to be positive, and I think just last week the High Court of Hyderabad has given an order to treat all patients at Gandhi and provide them with the life-saving drugs, irrespective of the RT-PCR positive or negative.
Yeah, my question to Dr. Parvez, because we are practicing in Hyderabad, so what is the approach for the patient once you suspect COVID? How to go ahead? So can you just give us briefing?
Yeah, so the question is, when you have suspicion of COVID, the main suspicion of when the main parameter is the clinical signs and symptoms. The patient presenting with viral illness, the fever, the cough, the body ache. I mean, the patient can present with the patient can have a variety of symptoms as the initial presentation, and the clinical acumen at the time to get the patient tested for the specific test, either RT-PCR or indirect markers like a CRP or a chest X-ray or a radiological finding on a CT scan, HRCT. That will be the way to go. So most of this, the non-specific inflammatory markers like a CRP, the LDH, ferritin, which are slightly raised in the initial stages. This will tell us whether this patient need further investigations and the further line of management. But the HRCT has completely revolutionized the way we are dealing with the patient in Hyderabad. It not only gives us the likelihood of the COVID-19, but at the same time we can quantify the disease based on the percentage of lung parenchymal involvement. So not just the CORAD scoring, but the total percentage of lung involved. That's a very pretty accurate prediction to see whether the patient may progress to a respiratory failure, and we can see or define the morbidity and the mortality.
Thank you very much. Thanks, Dr. Parvez. Second question, I would like to give the open address to the panel, Dr. Mateen, Dr. Fatima, Dr. Yadullah, is if you can share us regarding your approach with these patients in ICU, like how do you escalate your treatment, like remdesivir, steroids, and tocilizumab. So we can start with Dr. Mateen, the senior most pulmonologist on the panel at the moment. So Dr. Mateen, please kindly will be enlightened if you can share us how you're approaching these patients who is being admitted to ICU. At what level do you intubate them? At what level do you start the various antibiotics and antivirals and immunomodulators?
Let's go stepwise. In our circumstances, as far as the diagnosis is concerned, with clinical symptomatology, I hope I am clear.
Yes, we are very clear. We can hear you.
Yeah. With symptomatology, we are finding a good number of cases with anosmia and loss of taste or bitter taste, general body pains, myalgias, and extreme weakness. the complaint of breathlessness is relatively delayed in all these patients. And depending on these complaints, we had minimal facilities for asking for RT-PCR till recently. But nowadays, the government has given permission to private labs. Still, a significant percentage of negative cases are coming, which are false negatives. Because in my 25 years of practice, where I have always been keenly observing the high resolution CT scans of tests in various conditions, probably this is my first experience in the past 4 to 5 months where I am seeing patchy peripheral shadows within the areas of particular vessels. So what we have done is, instead of waiting, because this RT-PCR, we have to wait for 24 to 48 hours for the results. So we are asking for screening CT scans. Normally in Hyderabad, the CT scan is charged around 4,500 rupees. But now in our hospital and wherever facilities are available to me, we are getting within 2,000 rupees high resolution CT scan screening. And we are relying more on that because pretty characteristic pictures are coming. Even CORAD 1 and 2, we have not seen, because the classification which has come CORAD 1 to 6, even very typical CORAD 1 and 2 pictures are also strongly suggestive along with clinical symptoms that the things are likely to progress. Majority of cases we are recommending home management until and unless the saturations are falling below 88 or 90. Even for those cases, if the affordability is less, we are strongly recommending for home isolation and oxygen along with steroids and low molecular weight heparin under cover of some antibiotics, because we in tropical countries, the secondary infections are quite common. So here I end on this topic. Your next question was when we are admitting into ICU and how we are, yeah.
Before going to this question, regarding the CT, I think in Hyderabad is being misused. I have seen one patient, mother has a suspicion of COVID positive. I mean, suspicion is there, and the daughter is a breastfeeding lady, and no symptoms. And so somebody asked for the CT scan. Of course, CT scan be normal for her. So, CT scan is missed in Hyderabad. Do you think all the patients suspicion of COVID should go for CT scan or some symptoms?
Bad apples are there everywhere.
Yeah, that is very true. My father was in Hyderabad. When he went to Apollo, the first thing they did was do a CT scan to rule out COVID-19. For a minute, I was surprised that why this, because he was absolutely asymptomatic, actually had fallen, had a broken hip, and that's why he had gone to the hospital. So, but you're right, Dr. Salim, bad apples are every place. Yeah.
I would like to interrupt here, because what we have seen here is absolutely asymptomatic patients being taken to the theater. They are, number of our surgeons in my hospital have become positive. So after getting number of surgeons getting positive, we have decided that either a COVID report has to be ready or in urgency an HRCT has to be done. So I don't blame this particular thing at Apollo Hospital, because we ourselves have experienced that number of surgeons have become positive who are hardly exposed to these, because they are upper middle class people. They are taking care of total hygiene. They are not getting exposed to public places. Still doing surgeries. 3 of our surgeons got positive in a short period. So we have made it a rule that either we should have an RT-PCR report ready, or we should do a scan when we are doing surgery in emergency.
Thank you very much.
I just want to come in for a minute here for a few seconds. There is a flip side to the CT scan here. I have seen a couple of patients who were tested for RT-PCR because the family members were positive, and they got tested positive, but the follow-up CT scan was completely unremarkable. Completely, they were asymptomatic to begin with, and the CT scan was unremarkable. So relying on just one parameter, either RT-PCR or the CT scan or the markers, is not sufficient. It's the clinical acumen where it comes in play, where the symptomatology, the clinical suspicion, and the CT scan should be a aid rather than a test. So CT scan and should help in confirming the diagnosis rather than CT scan is the mainstay of the to diagnose.
Yes,
So
regarding
I beg to differ. CT scan doesn't confirm. CT scan is suggestive, strongly suggestive, or moderately suggestive. But confirmation is definitely with your RT-PCR only or antibody titers of IgM or IgG. So CT scan is handy for us, is easily available for us, and it is because the other reports we have to wait for longer time. So in our circumstances, we are finding high resolution CT scans very helpful to take adequate precautions. And as I am working in a corporate hospital, I realize that my daily outpatient is running to somewhere around 100 now. And out of 100, I am seeing somewhere around 70 strongly corona suspected cases. Because as you suggested, I go in a basic way. I take history, my assistant takes history, we tick certain things, then we ask for simultaneously if we suspect clinical syndrome of anosmia, bitter taste, tastelessness, myalgia, headaches, extreme weakness, we are straightforward asking for high resolution CT scan as well as RT-PCR. Still, all the hospitals doesn't have RT-PCR and patients have to run from pillar to post for getting RT-PCR done.
So,
Thanks.
regarding our
I'd
practice,
like to hear from Dr. Herar as well. Dr. Herar, welcome to the panel.
Yeah.
Regarding the CT scan, let us speak here. Regarding our policies in Saudi Arabia, Ministry of Guidelines, actually our CT scan is the last for us. CT scan will not be done until patient admitted to ICU. So we start with clinical data. So patient has got history of full symptoms, history of contact with corona patients, and history of travel. Then the suspicion is strong. Then we start with the basic treatment, like we use the azithromycin here and antibiotic azithromycin basically, and with a supportive treatment. Then we wait for symptoms. Most of the many patients especially improve. 40% patient improve within 2 or 3 days. So we not go for anything, not PCR, not CPC, nothing. So patient improve after 2 days. So just wait. We ask them to patient to isolate for 14 days. Because RT-PCR also, as the document said, we have patients go here and there for the difficult task also in Saudi Arabia. So just wait. Basically, we plan according to symptoms. Patient has symptoms, improve after 2 days. No symptoms, just wait and watch. Okay. Suppose patient is still having fever, high fever, fever for 4 days. Then we ask the patient to go for RT-PCR, basic workup with CBC, this markers. Then we will plan the treatment accordingly. So we not ask for CT scan as per guidelines until the patient are taken to ICU. Dr. Najib, I think, can give some comments about this CT scan.
Let's hear from Dr. Herar because he's also been involved in the city at the moment. Dr. Herar is a professor of internal medicine at OSC Group of Hospitals. He's also working as a consultant in Virinci. Dr. Herar, welcome on board. So let's have a listen what's happening in your clinical practice. Is the same as Dr. Matinuddin Salim or something you're doing something different?
No, assalamu alaikum wa rahmatullahi wa barakatuh. With a very good panel. In Hyderabad, what's happening is, as rightly said by Mateen sir, and I've heard Dr. Parvez as well. So what exactly is happening is there's no proper guidelines being made and followed here. At every place there is a lot of desire. As rightly said, CT scan is absolutely not a criteria. It has to be a mixed approach. About the clinical aspect is very, very important. As there is a lot of taboo and people are not taking the basic clinical history and examination. as that is missing, and there is a taboo of not seeing the patient and taking proper care. No proper PPE. So what exactly is happening is a misguide, and everybody has their own assessment. So most of the thing, and what is happening, the self-investigatory part is also very high. Most of the individuals who are no and so-called, so they are directly coming to us with lots of CT scans, and there is a lot of chaos happening. What exactly happening? Simple fevers. The individuals who are to be evaluated are not being evaluated, and the individuals who just have fever are doing their self-diagnosis. So I think what we have to do is we have to have with all senior individuals such as Mateen sir and all that, we have to have a proper guidelines at our setup also. I think that is missing at our end, especially in Hyderabad where we are practicing. There's not proper communication among our doctors as well, and we are not trying to just finalize a proper guideline, and that is why I think there's lot of issues happening.
I totally agree. I think there's a need to streamline the clinical practice among our physicians themselves, because everyone is having his own approach, and there is no clear-cut guidelines from the government, or there's policies like what we have in the West and the Middle East, and escalation of treatment. Unfortunately, because of the circumstances, what's happening, it's very difficult to stick to the guidelines in the Southeast Asia because of the various reasons.
Fortunately, most of my colleagues are from Hyderabad. All of you know very well what are our circumstances. The gap between the affordability, those who can afford and those who can't afford, has become extreme.
I had a question for Dr. Jabin, the last presenter. We are seeing cases where we have the patient come in, and our guidelines are that if they have 2 negative COVID-19 separated results, separated by 72 hours, we actually take away the PPE requirement or the isolation requirements. But what happens is after maybe a month even, if these patients develop a cough or something, not particularly symptomatic, maybe somewhat gray zone, if you may, when we test them again, they are coming back with COVID positive tests. Jabin, could you let us know what does that mean? How should we be interpreting that?
Yes, that's a very valid question, and we are seeing that increasingly 20 to 30% of cases, especially ICU admissions, we are seeing this sort of phenomenon where there are initial negatives and then a third or fourth test comes up positive. The study that I mentioned in my presentation looked precisely into that. How is it that these dynamics are changing? Is it just that the virus is going dormant for a certain time and relapsing or reactivating, or is it just dead virus? As I said, with PCR, you do find that. And the key to that would be in a lot of aspects to be considered when we take a PCR result on its face value. So as you said, when you have 2 negatives and the patient is asymptomatic, a subsequent positive really is of no particular significance unless it is repeatedly positive and it is going higher and higher. There is always a possibility of reinfection. As I said, because antibodies don't last very long and patients can be reinfected, there is that remote possibility, especially if the patient is coming back with symptoms, having resolved symptoms initially. But that is not a very common trend we are seeing. What we are seeing is patients who are have been in ICU, have improved, have been discharged, who are still asymptomatic, but then we see that odd PCR result coming positive. That seems to be a more common scenario. And in those circumstances, as I said, what we are hoping to do is actually get a feel of what these positives are. So we have started taking those samples and culturing them to see if actually this is live virus or is this dead virus.
Yes.
And in almost all of the samples that we have cultured, none of them have coronavirus.
Okay,
Can I
thank
come
you.
in?
That helps a
Can I
lot.
come in?
I'm sorry, go ahead.
Yes, Dr.
Yeah.
Mateen, please go ahead.
The thing is, there is always constraint of time. Now it's already 10:40 and I have to go for rounds. Fortunately, we have started a free service over here of oxygen, stay, nursing, and so number of patients are there. I have to go for rounds. I think the relevant point here will be we have to go for the management. Yes, I will try to give the gist of diagnostic capabilities of we in Hyderabad. We have to rely on clinical symptomatology, take proper quick history, then give symptomatic treatment to the patient. And if you have moderate to strong feeling that patient may be having corona because it has become very rampant here. In each family, we are seeing 4 cases, 6 cases. 2 deaths in each family, 3 deaths in each family. So the picture is pretty tragic here. So we have to ask for early detection and early aggressive management because we are a tropical country full of infections. We need to give a good coverage of antibiotics. And still I feel we'll come on to the management. We'll give a short or a long time for management because a lot of theory is already spoken. And if we give more time on theory, we may not be able to discuss the management. As far as in our circumstances, the diagnosis is concerned, take proper history, ask for RT-PCR, and simultaneously, if you strongly suspect, then better take an HRCT. The scenario here is whoever can afford, many of my patients means if I'm seeing 70, 80 patients of corona, at least 10 are coming already with high resolution CT scan to me. I don't know how it has become so popular.
I think it's a test of convenience rather than a test of that's what, because it's easy to get it done and the results are very prompt. If you do an RT-PCR or antibody assay, is going to take few days. I don't know what's the turnaround time of these assays in Hyderabad. So the CT is getting popular because of a lot of reasons. As you said, surgeons, getting infected. There's issues what clinicians don't want to operate on these patients until we have some sort of diagnostic testing, like the patient is COVID negative. I want to share my experience. When we went through the pandemic in UAE, for 3 months, we stopped all our elective work. So now slowly, now that we have managed to control most of the cases, so what we're doing that we're reintroducing the elective cases, even for a simple procedure like transesophageal echo or a diagnostic coronary angiogram, 2 days before the procedure, we send the patient for RT-PCR, and we tell the patient on the day of procedure, the turnaround time is normally 24 to 48 hours. So we call the patient on the day of the procedure, yes, your corona test is negative, or COVID is negative, you can come and have the procedure done. I don't think we have that liberty in Hyderabad. So, so the CT is a modality of choice. So it is convenient for both the physician as well as the patient. What's
That's
happening
true.
is that we are having a lot of tunnel vision with this COVID-19. We are forgetting that the fever and the symptoms could be because of a lot of other viral infections as well as bacterial infection. We still have to fight the dengue. We still have to go with the malaria, typhoid, other things. Also, we are probably getting into this tunnel vision of overlooking all these other diseases as well. Myself, we had one patient who been tested 11 times. This is a true fact. 11 times in our hospital, he kept coming back with recurrent fevers, night sweats. After 11th time, like 3 months, someone thought, okay, can it be TB? So he was tested for TB. Then he came out that he had a miliary tuberculosis by the time we diagnosed that. So it took us 3 months to come to a diagnosis of TB in this patient. 11 times he had his COVID tested negative. You know what? Nobody thought about it. So I'm just giving an example, like we still have to think about the outside the box as well for these patients.
True, pretty much true. And then the one last comment I want to make is this test, RT-PCR, CT scans, these are all to rule in, but there are no tests to rule out. So even if the patient has a negative CT scan, a negative RT-PCR, and the patient is getting a angiogram or an elective procedure in the hospital, the hospital staff should still consider the patient pretty much high risk, and it cannot just walk away without having the proper PPE and taking the general precautions.
I think the default should be.
If you permit me, I give two examples in a short time. Last week, a 36-year-old handsome Punjabi person came to me, 6-footer. He was happily discussing with me because his father suffered from COVID and he had no signs, no complaints, but he insisted that whether I should get a CT scan done. I said, look, you don't have any damn symptoms at all. Why at all you want to go and get exposed to radiation? And that is the place where most of the corona cases are also coming and getting CT scan done. The same night, he developed sinus tachycardia with a heart rate of 240 and a temperature of 103. I'm not saying this example should be taken. So I got panic calls from the primary physician. I said, do a carotid massage and settle the patient. Fortunately, they contacted another cardiologist also. That cardiologist also said, either you get to the hospital, we'll see, or you do a carotid massage. Somehow, within half an hour, the heart rate settled down to 130. Temperature also settled. Next day morning, when they brought him to my outpatient, his saturations were 90 on high flow oxygen. And when I sent him for CT, it was a florid picture of Corad 5. I cannot label Corad 6 because RT-PCR was not there. So it was a florid picture of the. One day prior to me, patient was happily sitting and talking to me. Another patient who came to me just complained of fever, myalgia, tingling and numbness in right upper limb. Next day, he got a severe and paralytic attack. I don't know whether it is COVID or not, but things are taking any shape here because I'm seeing too many number of cases. I'm coming across these cases also.
Good, thanks, Dr. Mateen.
Dr. Yadullah, can we?
I think we should hear what's happening in Saudi Arabia as well. Dr. Yadullah is an intensivist, alumni of Deccan Medical College, trained in UK, and is currently working in National Guard Health Affairs in Riyadh. Dr. Yadullah, welcome on board. I think this is the second time or third time we are interacting with you. So probably you can update us what's happening in Saudi at the moment.
Hi, everyone there. Now, coming to the question, there's a very famous saying by Albert Einstein. If your life depends on something and there's a problem that you need to solve, and you've got 1 hour to solve it, you should spend 55 minutes asking the right question and 5 minutes finding the solution. This applies here as well. What are the questions that we are asking? There's a huge debate about whether a CT should be done or not. The question is, should we be testing everybody for COVID? If so, why? And what are the implications of it? In our center, because it's a very resource provided center, anybody who gets admitted to the hospital gets a PCR test for COVID. It takes 24 hours for the results to come back. Until then, this patient is kept in an area which is for COVID patients. All the patients either on the wards or on the ICU are in rooms. ICU's rooms are negative pressure rooms. So they are to be treated like that. If somebody is going in for a surgery and you need immediate answers, you do a rapid RT-PCR where you get the results in 3 hours time. Nobody gets a CT scan done. CT scan is not for diagnosis of COVID-19, number one. Number two, when you're sending the patient for a CT scan, you are exposing lots of medical health professionals, right from the nurses to the radiology department to the area here where he's going and coming back, with the risk of transferring COVID if it's a COVID positive patient. The third question is that let's forget about the health resources and let's forget about the side effects that the radiation is causing to these patients. Third question that comes across is that whether it's a COVID or not a COVID, if somebody is ill enough to be admitted to the hospital, you will admit them depending on their respiratory rate, their saturations, and the symptomatology, whether they need oxygen, they need ward-based care, or ITU-based care if they need intubation. Now, whether getting a test back or not, what is the other treatment that you're going to offer them that's going to change the outcome? The answer is that you don't have many. The evidence is there for starting them on steroids. The evidence is there for giving them statin. Rest, there's bugger all evidence. You may consider giving tocilizumab if there's a cytokine storm or in a kid. Now, the question that you need to ask yourself is that you are getting into a whole cycle and circle that is being driven by lots of factors. One are patient-driven, other are organization-driven, but are we causing benefit to the patients? I completely agree with Dr. Mateen's statement that you shouldn't be nilly-willy testing CTs. We do CT scans in ITU patients only if we are suspecting certain things. Patient has been there for some time and is deteriorating. If there is a sudden deterioration, there's a high risk that these patients can have a PE. Are you going to blindly thrombolize somebody? The answer is no. The indication for thrombolysis would be somebody who has got a right heart strain and a saddle embolized and a systolic decapitation. Now, these patients can be on inotropes, so you don't know whether they're getting a systolic decapitation. Inotropes may or may not go up and down. And you need a diagnosis. If they're stable enough, then you will take them and do a CTPA for that one. Number one. Number two is that, is this patient developing a superadded infection down the line? Somebody you have given tocilizumab or other immunomodulating drugs, they can get aspergillus or fungal infections. That can be helpful. Okay. Now, the other thing that can be done is doing a bronchoscopy and sending the sample, but CT may give corroboratory evidence to that. CT showing a florid ground glass pattern, if somebody's sitting right in front of you, you wouldn't give a treatment to him. Maybe if he's on oxygen, you may consider starting him on a 6 milligram steroids. So we don't have really a treatment like for a cardiologist like you. If somebody comes with a chest pain, you want troponin right then and there, and you need an ECG because you're going to decide whether you're going to PCI him or not if he's got a STEMI. You're going to risk stratify him. What is there in here that's going to make you risk stratify the patient? You're going to treat him with limited options, with holistic medicine, rather than blindly doing things. There needs to be end to a means. Doing a helter-skelter thing is going to actually spread the virus, make the patient spend a lot of money without actually passing on the benefit. Should everybody be tested that comes into the hospital? The answer is absolute yes. For the sake of the patient, for the sake of family, quarantining themselves, and for the sake of healthcare professionals, there's no doubt about it. Should CT be used for screening? The answer is no. You take the patient, you quarantine him for 24 hours until the test results come back, or if he needs hospital admission, you treat him as a COVID patient rather than non-COVID patient. It's going to make no difference. I would like to also comment, there's a beautiful, though both the lectures are very beautiful. The first lecture that was given regarding rehabilitation, even in the most resource centers, it's incredibly difficult to initiate physiotherapy and occupational therapy at a mass scale because we don't have the manpower. And I agree with what has been seen in American centers. So we have seen in the UK centers and we are seeing in the Middle Eastern centers as well, people who get really bad, they're going to get bad critical illness myopathy and critical illness neuropathy. Added on to that, there will be post-viral myositis as well and myalgias. We haven't done enough muscle biopsies to prove that. Now, what we need to understand is that you do a lot of intense physiotherapy in the acute phase. In all patients who are admitted with influenza, pneumonia, and other types of pneumonia who go into multi-organ dysfunction, you work rigorously. Now, we don't have the staff, and there's a lot of PPE protection that you need to go and wear and start doing that. So that degree of rigorous physiotherapy is not available just for the lack of resources, even in the most well set up centers. There are lots of things that can be done automatically, like patients can be put on pedal bikes that are automatically being run in. There are lots of other therapies like music therapy, or sometimes people play on the recorder or CD player, Quran, or some other religious discourses or other stuff. So there are a lot of other collaborative things to help the patient. Delirium is always multifactorial in these patients, and it's hard to treat. Who gets delirious really badly. Avoid benzodiazepines. Do not give benzodiazepines. Completely agree, haloperidol should not be given. Dexmedetomidine or clonidine can be given as an eye infusion. Dexmed, I normally reserve for people who are about to be extubated. It's a costly drug. Clonidine, risperidone, olanzapine, these sort of drugs can be used as an oral. They can be given as an NG in intubated patients. The doses may have to be higher. But the thing is that you need a holistic thing. And you also need to be mindful of the fact that whenever you're using these drugs, that these drugs come with a price. Do a daily ECG and look at the QTC. I have seen patients going into really bad dysrhythmias, correcting electrolytes, keeping the electrolytes in a normal range, making sure their thyroids are fine. They're making sure you give right drugs. People who are spiking temperatures, they don't respond to digoxin, in my experience. Even when they have given an imidazole, they are resistant. And I have not shocked this many patients in my life as I've shocked in the last 3-4 days. If somebody is getting a rapid rise in their oxygen requirements, I would anticoagulate them until there's a strong reason to. I've seen patients coming with pure strokes, malignant MCA infarcts. I've seen patients coming with just P's. I've just seen patients coming with just myocardial infarctions, not having respiratory symptoms. So it's very important you should be asking the right question for that particular patient, not as a group, and acting in that. Regarding the case that Dr. Mateen said that the patient came in and the fluoride 48 hours, he went on to have the presentation. Even if he did the right thing, I would have done exactly the same thing. I said, go back, we don't need a CT scan for you. Even if he did the CT, he would have said, you're fine, stay at home. If you become symptomatic, come over here, but isolate yourself. We should follow a blanket policy. Anybody and everybody is COVID until proven otherwise. And use the test in a very sensible manner.
Thank you very much.
Can I keep it now?
Yeah, definitely. Dr. Mateen, go ahead.
Since I got information just hours back to come for this panel discussion, I have not mentally prepared to express myself methodically, but I'll try my best to go stepwise as far as the management is concerned, because I'll be here for about 10 minutes and I have to quit. I'm sorry for that, but I'll just take 5 to 10 minutes to go stepwise. I'm really feeling happy, the level of discussion going on and people expressing their views in terms of clinical experience as well as the microbiologists, virologists, and rehab specialists, the way they have expressed. But here, the caseload is so much and the doctors are so few. We need to take quick decisions. We need to take appropriate decisions. So now, the basic pathology here is microvascular endothelial damage. So anticoagulants, I meant prophylactic anticoagulants in the form of enoxaparin at 1 mg per kg body weight in 2 divided doses. It is not a therapeutic dose. What Dr. Yadullah was telling, that until and unless we have that proof, it is only prophylactic dose, because what we are seeing here is microthrombi in microvasculature, thereby leading to failure of different organs, CVAs, ARDS, liver injuries, GIT injuries, as well as cardiac events. So we are giving, number one, symptomatic treatment. Number two, we are regularly covering with antibiotics, which should cover atypical organisms as well as gram-positive and gram-negative organisms. In this regard, we are using either azithromycin, which is a macrolide antibiotic and also has anti-inflammatory action. That covers all atypical organisms and majority of the gram-positive organisms. A wide spectrum antibiotic in the form of either augmentin or oral cefpodoxin proxetil or injectable ceftriaxone, or if somebody is savvy enough, can go for higher antibiotic. But being here, with overcrowding of people and not maintaining so much hygiene, secondary infections are pretty high. Even if some ICUs claim that infections are less, I have strong doubts about it. So symptomatic treatment, good coverage with antibiotics of atypical as well as wide spectrum antibiotics, anti-inflammatory in the form of steroids, which the UK study has clearly proven. We are using steroids for past 4 months in almost all the people, and we are getting pretty good results. The mortality rate with us is, I don't want to boast, but it is pretty low. We have lost patients, but it is pretty low. Fourth thing is prophylactic usage of anticoagulation in the form of enoxaparin. We are not using fondaparinux because it doesn't cross the blood-brain barrier, so it cannot prevent the CVAs. And we are trying to avoid unfractionated heparin because the molecule size is bigger, and though the control is good, we can use, but close monitoring has to be there if we are using IV unfractionated heparin. So we are more or less avoiding in this load. So symptomatic treatment and good coverage with antibiotics, steroid usage, and prophylactic anticoagulation. In addition to this, there is severe loss of appetite, loss of taste of the patients, severe myalgia. So we are inadvertently adding up B complex, vitamin C, folic acid. I don't know we are right or wrong, but we are doing that thinking that there is no harm and these are cheap things. And coming on to when we should go into the intensive care unit. If I am too long, you can interrupt me.
Okay, one question. Regarding steroids, when to start steroids? Patient is hypoxic or without hypoxia, you can start. Because the first week is a viremia. So can we give steroid this stage? This is a concern.
Yes. Into distress and symptoms when the viral load is high. Okay, so the anti-inflammatory product which is available to you, which is relatively safe, is only steroid. Either you use dexamethasone, or you use methylprednisolone, or you use hydrocortisone. I don't prefer hydrocortisone because it causes a lot of water retention, and in critically ill patients, I try to avoid hydrocortisone as much as possible. Am I?
But data shows that patient with steroids used without hypoxia has got high mortality than the other group.
The UK study has proved that. The UK study has proved that mortality has come down with the usage of steroids.
Without hypoxia, they say high mortality. Patient getting steroid without hypoxia, they got high mortality. Dr. Yadullah can come in. Dr. Yadullah.
He moved out.
Yeah.
He's moved out. I think I'm just trying to be mindful of the time factor.
Dr. Fatima, we didn't need to call Dr. Yadullah. Dr. Fatima
he's back. So can you repeat, ask your question again, Dr.
Yadullah is back. Yadullah is back.
Yeah.
In terms of giving prophylactic anticoagulation, we strongly recommend prophylactic anticoagulation. In the lecture that I have presented, we go by the D-dimer and the weight. So the British Hematology Society have come up with guidance on how much of enoxaparin is to be given depending on what the D-dimer levels are. It is much more helpful. I completely agree that this infection causes infectio endothelitis that leads to thrombi forming even in patients who are asymptomatic, and this helps in preventing. Now, we don't have data how effective this is but these are the recommendation of the European and most of the organization, and the general consensus among the expert is that they should be on that if they are positive. Now, in terms of multivitamin supplements, antivirals, and antibiotics. Now, antibiotics should be given to give a good respiratory coverage. There are lots of studies that have come in about inflammatory stuff being modulated. So I was the research lead in the Epsom Centennial years, and I was a PA for lots of studies. And what I have seen is that there's colleagues of mine who have tried cotrimoxazole with azithromycin. And they said the results are fantastic. But what we need to understand is that there are patients who get better irrespective of what we do and what we don't do. Now, can we attribute that to our treatment? Because we know that only a minority gets really bad and really sick. Now, your results will look really excellent and the mortality will look really good if your denominator is very high. So if you are testing 1 lakh people instead of 1,000 people, so if you look at the UK data, the mortality is high because a lot of people got infected, but only the most ill got tested. The testing wasn't that good in the beginning part. So if you're testing a lot of people, then fewer people are going to die and you're going to look good. No doubt. But if you see in the whole holistic pattern, the numbers are still significant. And the numbers may fall from 1% to 5%. What really decides that number from going from 1% to 5% in my personal experience is that the availability of healthcare resources for doing basic things right. Now, I have been in contact with my colleagues in Italy, Belgium, and other European countries, Germany, where I have gone and done fellowships in ARDS management and infections in ICU and delirium management, and what they have been doing in these subset of populations, and to try to corroborate from their experience the universal experience has not varied much. We are only using other stuff in the form of trial. For example, if somebody is being convalescent plasma, somebody is being given antibiotic along with something else, somebody is being given multivitamin, or somebody is being given fopinavir or other remdesivir or Kelatra. It is only in a trial setting that we are doing it. Otherwise, outside trial setting, we are not doing it. One of the points, there was a patient that was presented, LJ, in the first lecture, and I'm not sure whether the patient received Kelatra, because if somebody has received Kelatra, they can get facial muscle atrophies, as you see in retinal patients. I'm not sure whether that was given or not. So it's very important that whatever you're using, the patient may get better. Is it your treatment that's making the patient better, or is it the disease process getting better? The patient, in my opinion, does not die from the virus. The patient, in my opinion, dies from your body's response to the virus. So if the body is having a marked endothelitis, infection endothelitis, then they get clots and mitral thrombi and die of some thrombotic complication. If they have got a SERC response or a cytokine storm, they die from either ARDS or a multiple organ failure. And most of the patients that develop respiratory failure going on to ventilator support with a renal failure going on to dialysis or another modality of RRT, 88% of the patient dies. So the results are bad if you've got 2 organ failures in them.
Thank you very much. I think in interest of time, we should draw the curtain for this today's seminar.